Hi, everybody. I am so excited to be able to do this. Normally, I would be very interactive and call on you and make this very Socratic, but I was told that's kind of mean and off-putting in the beginning. But then students do begin to like that strategy. I'm excited to speak with you all, first because preparing for this talk, I was reminded of my own path. I remember being a third-year medical student in UC Davis, and it was kind of like a movie. I just sort of looked up one day and I said, it's not enough. I was kind of treating the same people over and over, and I knew that there had to be something else. I wasn't quite sure what that was, but it ended me in public health school. And I have to say that that academics decision was probably the most impactful decision in my career, at least. But I'm also excited because of this new guard. The public health community needs a new generation of health fighters who have a bias towards things that impact the most people, so population-based, which also means looking at fundamental determinants of health, including human rights, including things like climate. And there's opportunity now to make a difference, now more so than ever. We have a lot of different types of talks this week, and I thought that one area that I could contribute to was in work in the field. I specifically have worked for a long time living in Rwanda, Liberia, and Indonesia, a few other countries, but I'm just going to pick these three areas. I think this is one of the distinguishing areas of an education at NYU. I did not have really any exposure to global health work in the field when I was at the School of Public Health at Berkeley. That is not to impugn it. It's just to say that every institution has their own bent. And at UC Berkeley, it was more public health and social justice, community health, community organizing. But at this particular school, I do think there is a lot of emphasis on the global nature of health, and that is to work in other countries, to work with other partners, to work in with a lens, knowing that there are multiple sites, participants, viewpoints, and tools that are necessary to solve very complex problems. All right, so let me just get a little bit more specific and see if this works. So I will count on my colleagues to yell at me when there are questions. If people don't feel comfortable just yelling it out, or if things on my slide are not working. Okay, so I want to be very respectful of your time. So I was thinking that really the objectives of this will be like to really pat you on the backs about this decision to pursue public health as a profession. You will not regret it. And it doesn't matter where you go, but you will not regret that greater decision. I do want to talk about the types of things that you will learn that could prepare you to work in the field if you decide to do that. And then finally, I'll show application of those lenses and tools that I believe makes us more effective for the people that we try to serve. So let me just go to the very beginning. I, again, didn't really have much experience working abroad. In fact, I was kind of scared of working abroad. I would just get homesick every time I would, go to Taiwan or, my homeland, and I just want French fries and hamburgers and go to sleep in my bed. I just really never thought that I would live in abroad for extended amounts of time, and certainly not in Rwanda, at least in 2007. But I had read a book I read this book called Mountains Beyond Mountains. Um, and I was then working in the United States Senate doing health policy advice for a senator. And I had again, one of those existential moments where I looked at the sky and said, this is not enough. I know how to make policy now. I know the sausage making, but where is the actual application of all this? It was so distant within the literal marble of Capitol Hill. And so I decided to work with Paul Farmer and his organization Partners in Health. Of course, that did not necessarily happen right away. I said, hey, I want to volunteer for you. I didn't hear anything back for 3-4 months. I realized that I knew the co-founder through my sister, and I decided to write him an email. And over time, I got to work with Paul Farmer in Rwanda. And that would be lesson number one. I've never had a job that I got just by applying by email. I would almost always have to personalize it or hit the pavement and knock on the door of the organization or the person that I want to work with. We became very good friends. Paul Farmer died of a heart attack last year, and it he was a really kind of crazy, really powerful person. One thing that it reminded me that despite his power and his influence in really developing international health, he died. And so you have to, when you work, whatever you decide to do, realize that life is precious, life is long. You want to live it to its fullest, because you never know when it's just going to stop right there. And I believe Paul led a very fulfilling life. Um, it is so funny when you do work in the field, you think that just have stereotypes. You don't really have any experience. So I thought I'd go to the bush, whatever that meant. I thought it'd be very green. I thought, my diet would change. And instead, my first day, since it was New Year's Eve, was to party with every character in that book, including Paul Farmer and his beautiful wife Dee Dee, who's on the right, and Catherine, their daughter, who is now a grown up and probably doing great things. But it was very surreal, and another lesson about you really don't know anything until you actually are doing something. Well, Paul took me immediately to the prisons, and some of you might remember that in 1994 there was a 3-month genocide based racially, so based on nonsense, in which 1 million people were hacked to death by machetes, neighbors against neighbors. So he took me to the jails where everyone wears pink, like pink pajamas, but they're in jail. And we proceeded to diagnose and treat all those in the jail that had HIV. And back then, there wasn't the cocktail yet. So this was, sorry, there was a cocktail, but it was still very new about how to spread HIV therapeutics in a way that was, quote, sustainable, a word I hate. And Paul taught me to hate. Sustainable being like what you really want to do, what the power structure wants to do. But I just remember being kind of scared about drawing blood and treating those that had hacked, they were in jail because they were perpetrators of the genocide. And Paul was just normal. He kind of just said, like, I don't care. My job is to deliver care. Let someone else decide about the context in which things happened. And that was a great lesson, is that, again, you don't know anything about anyone, but you do know that you can always be of assistance to people in whatever context. Now, I didn't know anything, but it turns out that all that difficulty in getting to Rwanda, I always thought later, like, why was it so difficult? There's no one here. So basically, there was a health center, but no hospital to treat over 500,000 people. And so my job was not to build the hospital, but rather to run the medical operations while the the directorship could focus on the actual construction. And so this relied on, much on my medical training, less so much on me doing procedures, but more on me teaching and coming up with the processes of care, which have to happen in a hospital. I lived in this community, and I remember very dramatic things, and most good, but always dramatic. Rwanda has the densest population on Earth, like in terms of like bodies per square foot, and and there just were not enough doctors. And I just remember every night, even though it wasn't necessarily my turn to be on call on night, I would hear the tap 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 of the guard against my window, and that just meant that someone had come in very, very sick, and I just had to make a decision whether I'd have to go up. But I would have this tap 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 happen basically every night for a year, and it really challenged me to ask myself what is important, but to come up with systems that could not have to depend upon someone me to decide whether I want to get up to try to save a life. I lived in the community, and that was another take-home point of being in Rwanda, is that you want to really personalize it and not separate profession with personal, in my perspective, in the global setting, because it fulfills you. It makes you just so much more grateful about where you are, and therefore more effective. It's just a staff versus community soccer game. I play basketball, so I was just watching with the community, but it's kind of funny. You can see I kind of stood out there. I think I spent like 2 months teaching people that I was not white, and then next another 2 months teaching people that I was not Chinese. But you kind of have to like that. I'm not saying the chaos, but I'm saying like you kind of have to like being with the people that you're serving, and that's very easy. But I just want to say, kind of the obvious. It makes it so much more fun, as you saw the fun that was being had at the goal scored against the Mzungus, or the foreigners. This is a case that I thought was just so interesting. It was another lesson taught to me by Dr. Farmer, was that you do everything you can for anyone that crosses your path in international health. It doesn't really matter what it is. If it's not in your job description, it's not part of the logical framework. I remember I had this child, and he just was not getting better. I mean, he just lay there. He had some vomiting and maybe a little bit of diarrhea. Then it turned a little bloody, but then he looked kind of okay. I mean, he wasn't screaming or anything, but he kind of lay around like this for days. And I'm like, this is really strange. And I asked Dr. Farmer if I could transport him. He said, well, it's a 3-hour Jeep ride, and it's going to involve lots of money, but if you think we should do it, I guess we should do it. And I'm like, let's do it. And so I transported him. I turned out that the only hospital where that would really care for our patients was the private hospitals. I would usually involve, payment and then a pineapple, but I basically did a CT scan of him. Again, no stereotypes of what a place is. And it turns out he had something called intussusception. And that is when the bowel telescopes into each other. And you can see it right here, like, it goes like whoop, like that. So I bring this up because just yesterday, I was working in the emergency room and I had this child that was who's just kind of just lying there like this.
And the surgeons are gonna meet you up there.
Mm.
Okay.
Do you have the diapers from mom? Yeah, this one. That one.
And he was going to be admitted, but just, for hydration. I'm like, that reminds me of that kid from Liberia. And in fact, the kid had that same stool where
The surgeons are
stool
gonna meet
was,
you up there.
oh, sorry,
Okay.
was sort of a little graphic, but it's called current jelly stool. Because the bowel is like pushing against each other and kind of killing the tissue from pressure. And instead of a CT scan, we did an ultrasound. And can you see that it looks exactly like that? So I felt like, in a very strange way, that the lessons, I would never have gotten that diagnosis if it weren't for Rwanda. And that was 20 years later. And so I thought that was kind of interesting that things do go very full circle. It was very tragic to leave. It's like leaving a family. It has to be done at some point. And it has to be done carefully, just as you leave carefully, you enter it carefully and you leave carefully. Especially nowadays, we're more aware of being too colonial, colonial constructs and actions, uh, oppression of people led to many of the things that we try to fix in public health. So it'd be very ironic if you go to the field and you perpetuate it, right? Or don't acknowledge that. And sometimes it's hard to figure out what is a good balance, but on the other hand, it's not. You just go and you see how people respond to you. And I always felt that it was very bidirectional. But again, you'd have to ask other people and triangulate, of course. Okay, so I then went on a career to public health domestic. I worked for the New York City Department of Health as a medical director. Um, I would say it didn't go very well. I would say that I did my job. I was fine. It was respected. But in terms of me feeling like I was making a difference, especially after the Rwanda experience, I thought, no, I think I needed change. And so I decided that I would go abroad back to sub-Saharan Africa, and I decided to go with an organization called the International Rescue Committee, about a $1 billion nonprofit organization. Of course, they didn't want me. I submitted an application. I got nothing. I didn't have any of the credentials. I wasn't part of the NGO world. And so I basically went to the office and I knocked on the door and I got an appointment with someone. And he said, well, I'll shop your stuff around. And then 2 months later, I left. Of course, I didn't know where Liberia was. I didn't know Liberia was one of only 2 countries in all of Africa that was not colonized. It was called Liberia because it was an effort by the United States to create a place for freed slaves to return back to the quote home country. The capital is named Monrovia, based on President Monrovia, Monroe, who initiated this endeavor. So I'm going to say I lived there, and it was fine, and it was great. But then I left to go to Indonesia, which we'll talk about. But then Ebola hit, and I was asked to return to West Africa on behalf of the International Rescue Committee to try to lend assistance. What that means is that I was comfortable in Liberia. I knew the director of health. I knew everybody. I liked it. There would be no learning curve. And just to test the audience, where do you think Liberia is? Do 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 do. There. Very small thing. Oh, I circled Cote d'Ivoire there just because when I was first there was a civil war and people would stream into Liberia, which is a whole nother um, uh, interaction. So I was tasked to set up the processes of Ebola treatment units, which were used to essentially isolate those who were very sick from those who were healthy. It's the only way to control this particular pathogen. But I didn't know anything. And I think that's one lesson, is that you often don't know anything for things that you never planned for. And that will be common in public health, but you'll be trained on like learning, and you'll be open to learning, and you will never say things like, I know things that I don't. So one very impressionable training that I had in oh, I forgot. It's next to Georgia. Oh, Alabama. Yeah, I don't say that because I've never been to Alabama, but I was sent there to learn about how to take care of Ebola patients. Again, I'm a pediatrician. How would I know how to take care of Ebola patient? We don't have that in this country. And then how not to die from taking care of a patient who is dying. So we learned how basic treatment, which is basically give hydration and nutrition. And then we learned how to put on the PPE and to take it off. But just to emphasize how getting one viral particle on you could kill you. In the very end of the doffing process, donning as you put it on, doffing the process, they would throw powder on us. And then we go through all the process. And then when we got to the green area, the area that was, away from the doffing process, they would shine a fluorescent light on us. And if there was one speck of fluorescent particle, if there's one particle that fluoresced, they would say you're dead. So there was a whole bunch of us. So they would say, oh, you're alive, you're dead, you're dead, you're dead, you're alive, you're dead, you're left. So it made a big impression, because in my job, even though I'm setting up the processes for medical care, big quotes, I had to make sure that the staff that I was recruiting would not die. So one question to this audience, which you will be able to answer if you came to an institution like ours, would be, name all the things you might engineer to protect your workers. That's one question. So think about that. Like let's say your job is you have to protect your workers. Like, of course, one dies, then the whole thing is like done. The other is, how would you know your ideas worked? So I'm going to take you through the process that I essentially learned at public health school. And many of you probably might even know it. But the first thing you have to do is you have to go backwards. You need to decide, how would you know your idea worked? And then you would have to name the things that, because if you can't measure whether you are accomplishing what you set out to do, then you get kind of stuck. So you have to decide, how do you know that you achieved your goal, that it worked? And in this case, it just means 0 infections. No one gets 0 infections. But as an indicator that you got what you want, it has to be smart. And we'll teach you this. The thing has to be specific, measurable, attainable, relevant, timely. Of course, 0 infections are all these things. But you might come up, if you don't know smart indicators, with something like, people have to be protected, or people can't be scared, and they would not be smart indicators. But this was a smart indicator, 0 infections. The other piece is, in engineering an outcome, is that you usually have to focus on a behavior, usually just 1 or 2 behaviors, and I would call it a vital behavior. So you could say, oh, let's just teach them not to get Ebola, or to be careful, well, it's not a behavior. you would have to think of what would you want, the one thing that could be seen and done over and over, perpetuated through the system so as to get the results you want. So you want zero infections. Think to yourself, what would be the one behavior that if you could get your staff to do, they wouldn't get infected? This is key because everything is contingent on this. So the one vital behavior in our case that I came up with was health workers follow standardized doffing steps, right? Because there is a standard. There's a way to do it. Can you see there's a difference between saying, oh, you just want the health workers to be careful. Oh, you just want them to follow the steps. Well, no, you want them to follow a standardized steps. Now that you have the vital behavior, you say, okay, how am I going to implement this? And then you'd be a good start is like, oh, look at CDC doffing procedures. You're like, holy Toledo, how is someone who's stressed out going to follow CDC doffing steps? But you fall back on behavior engineering that you learn in public health. And you realize first, you can make things obvious. Now, I remember when I was creating this for our workers, that in the 70-year history, no one had actually just written down all these steps in graphical form. And I certainly don't know how to draw. So I got the intern to draw it because she was a great artist. So we put this thing together. We took established protocols and we just made it more tangible. And that would be another lesson in public health work in the field, is that sometimes you have to be creative, but your creativity is not even that creative. It's just like obvious. Sometimes you have to do the obvious, but the obvious is not even there. So they categorize that as creative. Anyway, I thought it was a beautiful moment, but it's not enough, by the way. I mean, would you say like, oh, say to your director, I've come up with this poster that will make sure, if someone's rumbling around, sorry about that, make sure that will guarantee zero infections. And they're gonna like, that picture? I mean, it's a nice picture. So it turns out there's actually more steps to it. And I don't want to go into detail here, but I want you to know that behavior engineering occurs within categories. Not only do you motivate, don't get Ebola, but you have to give people the ability to do that. And in addition, we're complex creatures. So not only is my motivation important, but my community is important, peer group pressure, and so is structure. So you'll just see that for personal motivation, we don't just say to people like, hey, you really shouldn't get infected today. We would put things like a morning safety announcement and say, put the sign in the doffing area, this is where you die. Right? Something a little bit more than don't get infection. Or in community, we would reward people. We would make sure that people work in pairs, and we reward people for squealing on people that want to kill themselves. Right? Now, those people would be fired, those people that don't pay attention to the protocol, but we would reward people. Structural, we do automatic firing for policy violation we talked about. So you can see that there is a engineered way to make sure that to get people to follow standardized doffing procedures, which remember is our vital behavior. And this has been studied. If you can cover 4 of these squares, you increase the probability of the behavior happening 10 times. Think to yourself how many times in your life that very important people have dealt with an issue of great import and just said, like, we will educate them. We will punish them. Public health people don't do that. They engineer a core set of behaviors. And so that is that example. I want to say that, okay, I said there could be 2 behaviors. So on the staff side is you follow standardized operating procedures, but how about what would be the vital behavior of the community so that you could control this epidemic that didn't turn into a pandemic, but could have. But we were lucky, not because the system did what it was supposed to. Think to yourself, what would be the vital behavior? Drum roll, please. Da-da-da-da. The MOH hazard teams, Ministry of Health. So you don't want people just to go themselves, right? Because they're going to affect people. They would go and bring any Liberian with fever and vomiting to a government Ebola treatment unit. You see how specific that is? I didn't just say like, oh, you go to the Ebola treatment unit. Oh, if you're bleeding out of your ears, you go, it's very specific what particular behavior. And then you would just go through, how would you measure that? How would you engineer that within those behavior influence squares? Okay, so this is the last example, Indonesia. I lived in Indonesia 2013 to 2015 with with work in Liberia for the Ebola. I went back then I was working for USAID project to reduce maternal and neonatal mortality. Indonesia is a very strange place. It's like really nice. Like you could go to a mall that would put the one mall that we have in New York to shame. But on the other hand, it had maternal and neonatal and health indicators rivaling Cambodia. So it's the seventh largest place in the world. So there's a lot of stakes in making sure that this very populous place has a good healthcare system. And by the way, probably next avian flu pandemic, just by nature of geography, will come from Indonesia. So I work for a USAID program, and my job was to make sure that the quality of the program was what was stated. I was the senior technical advisor. And so I did that. But before I did that, I'm like, oh my gosh, I've never been to Indonesia. I never worked with Asians, actually. Where is Indonesia? All these things. And again, I wanted to say that even with Ebola, although I didn't emphasize it, it's so cool to just live somewhere else and just kind of feel it. Like, here is the end of Ramadan. I actually not Muslim, but I practiced Ramadan in respect for my colleagues. And this is the end of it, where you wish someone a sort of clean spirit and brain. And so I just love the rituals and the my colleagues, my friends, my people, my community that I was with. You can see it's quite comfortable. And then of course the food is pretty awesome. Not to bag on Liberian food, but Liberian food it doesn't kind of compare. So my job was to go and to make sure that the program was doing the right thing. And of course, they were pushing what you see, or in any public health school, they're pushing neonatal resuscitation, treating of preeclampsia for pregnant mothers who have high blood pressure, prevention of postpartum hemorrhage, kangaroo mother care, and encouraging of breastfeeding for sick babies. And so what Paul Farmer had taught me is that don't go for the tour, just go work in the hospital, like sit there at night on a weekend. And you kind of see very quickly what's going to happen. And I realized, and I'll just use an example, there are many different types of examples, but for babies, that the babies were not getting fed. They weren't getting fed for a couple of reasons. These are all hospitals in Indonesia, basically. They're not getting fed, because they're too sick to be fed. And then B, sometimes the mothers, they don't breastfeed well, immediately after birth because they're sick, etc. And so the babies get an IV put in them and the liquid just flows. And this was an obvious reason why the neonatal mortality rate was so high. And you could see that in addition to, if you looked at the scale, that it doesn't work, right? Here it says it's low, right? But then when you looked at the chart, you don't have to speak Indonesian, but here you see Barapadan, right? Which is, oh, by the way, learn languages, the countries that you live in is awesome, means your weight. And I know that babies weighing, gain 15 to 30 grams a day. But these babies were at 1200, 1200, 1300, and 1200 again. So I knew that there was no weight being done. So we came up with an intervention. It's kind of easy, so easy, right? You don't even have to speak Indonesian for this, is that the babies would be weighed, right? So let's say it's 2.4 kilograms, a little bit over 5 pounds. And then the baby would then have to be fed 45 cc's every 3 hours of formula, right? So these are people like babies that are sick, can't breastfeed, right? Now they can't suck, then you put a tube down their throat, but it can be easily done. Here's another example. Oh, you are 2.5 kilograms. So then you will give 47 cc's. We did many studies that simply to feed the babies, you would decrease the mortality over 50%. It didn't need anything else. But it turns out there were no scales. Like, who has a scale? And it turns out the scales that we use in the United States are like $3,000. So I settled on a vegetable scale, $12. Everyone got a vegetable scale. And then we ripped off the top part of their old scale. And that's what we used to weigh the babies because we needed to the nearest gram. And then, of course, we had to do some teaching. But you can see it was kind of easy, right? You just kind of look at the piece of paper, blah, blah. Eventually, we came up with the equivalent of checklists for every maternal and neonatal emergency that there was. And here was the booklet. And of course, we converted to Indonesian. And I felt so happy. How do you think my organization felt? Basically, I was fired. I was fired initiating this intervention. I've only been fired twice, but it was quite traumatic. But it was my fault. I was entrusted to come in as a USAID representative or sorry, to support a USAID grant that had already decided the intervention a long time ago. I was maybe to tweak it, but I was not to fundamentally upturn. And I had thought to myself, why didn't I pay attention to that leadership class that I took in public health that talks about, like, if you're going to make change, you better do it with colleagues and with company. You better be a known entity before you decide to deal with the politics of making people angry. Don't always think that you're the smartest person in the room. So after giving myself like a month to be seriously depressed, it helped that I went to try to fight Ebola. My wife was still in Indonesia. I said, I still got to do something. I still believe the idea. Now, the way I did it was totally wrong, but there still has to be a way forward. So what I did is I started with this idea of behavior again. And I said, the problem in Indonesia, from my experience and through study, was that the health professionals, they don't follow protocols. Just like the Liberians, or just like you want someone to doff correctly, don't you want your healthcare provider, whether it's a doctor, a nurse, or a CHW, a community health worker, to follow an evidence-based protocol? But my experience was that 70% of the time, and just so you don't get too arrogant, in this country, only 40% of the time, 70% of the time, the doctors did not follow the protocols. And the differences between here and there is that you die. So I systems mapped essentially I systems mapped this problem, and it's very easy. You say, okay, let me see, you start with a problem. I just reversed this to a solution. You start with a solution. You say, okay, health professionals routinely follow protocols. Okay, idealize that. How would they do that? And you can see, oh, they have access to those protocols, right? Oh, they have enough prerequisite training. Oh, they have all the tools necessary. And then how would you have all the tools necessary? Oh, you would just keep on going that. And that is systems mapping. it's beyond, and this is what you learn though, is that's how you come up with the logical framework for interventions, with the very bottom pieces being activities. And then you think to yourself, going through this behavior change, what could I do that was coherent to make sure that those activities happen? And so, of course, it decided to involve technology. But I wanted to make sure that it wasn't stupid technology, like the technology that I was seeing left and right, whether it be in sub-Saharan Africa or Southeast Asia, where people would this would be very typical, like text messaging to poor people, rich people text messaging to poor people, or bots text messaging to poor people. Is your baby breathing fast? If so, go to the doctor immediately. The hospital is dirty. The last time I brought my child there, he died. Is your baby having diarrhea? If so, go to the doctor immediately. One thing that was very obvious to me as I decided to go be a little bit more techie in my approach was that you would never develop something abroad that you would not use here, because that's called disparity and perpetuation of equity and colonization, right? So you wouldn't do something like this. So I thought to myself, well, what would we use here that we would use there, or should we use here that should be used there? And I thought, okay, whatever it is, it has to measure how the system is doing. For example, I know that medical care is a business, so we'd have to look at okay, how much money is being made per unit time, but break that down, like where are the where are the drugs that are making the money? Where are the drug stockouts? I know that had to be considered, right? It wasn't my emphasis, but I'd be dumb not to think about it. But then I cared about what was in the middle. Like again, the behavior is adhering to protocols. So I want to measure adherence to protocols. And I want to do that, and you see in the very top, as a total. But then I want to see every single diagnosis, right? Because you're a busy program manager, director. You're not going to just focus on pharyngitis. If people know how to do pharyngitis, you focus on the things that the system's not doing well. And of course, if there's any deaths, that should be highlighted immediately. What kind of health system do we have if someone dies and you're like, oh, sorry, I was eating a hot dog in the mall? I mean, that would be the wrong type of intervention. So you would need to highlight any quote sentinel event while looking at the things that are a little bit more mundane. So I came up with this, and this is just a short, you learn when you are a CEO or a startup that you do everything. So I started just doing videos myself. And so this was one of our first promotional videos made for $200, $220.
The outpatient clinic where most people in the world receive their health care is decades behind other industries. One problem is that most medical documentation is still done by pen and paper. This leads to lengthy registration times, doctors spending more time with charts than with patients, and serious risks for miscommunication. Another problem is that doctors, nurses, and midwives don't get much help with decision making. With over 50,000 diagnoses and 4,000 medicines, it's hard for clinicians to figure out what to do in 10 minutes. Patients better hope that their doctors graduated at the top of their class, or that this year is a much better year than last. Walking Doctors was founded to tackle delays and mistakes in patient care anywhere. We focus on what is common to all medical practice, the medical record, making it electronic for instant referencing, building in disease checklists for faster, correct decision making, and displaying health facility outcomes for documented impact. The end result is complete, effective, and transparent care for the patient-provider experience out. This has system-wide effects, including 100% increase in protocol adherence across all diseases, and a growing cadre of happy customers committed to quality care improvement. With Walking Doctors, health staff finally have access to the tools that even superheroes require. Who will you save? We are Walking Doctors, quality care anywhere.
Come on, that video is worth at least $225, don't you think?
The
So one point of this is that I worked outside. I had to create my own company because I wanted to do what I need to do. But in terms of NYU, I've learned so much, or I'm so grateful to the institution because they still allow you to be yourself. right? I am NYU visiting associate professor. That comes with a certain identity, but I also bring with me my identity. I bring an identity and contributions from my side, which people are very open to. And that will be the same thing for students. You will come with an identity and a body of experience that will be appreciated by the institution. And then combined. And so what I mean by that is I've really learned and been happy with a lot of the partnerships that I've developed. Like I write grants and I'm not that great with epidemiology and biostats. I need the departments to help me with these endeavors on the hand, and they need me a little bit with for implementation, which I'm a little better at. Patricia will know because he was a recent graduate, and congratulations, Patricia, again, of the Stern Business School. But the Stern Business School has programs available to entrepreneurs that teach you how to do startups. They have contests. They have, you can also take classes there. But I mean, this is be something even that I participated, where they teach you things that I learned the hard way, like the triple threat of product development. Like, oh, I always tell my programmers, I want this, and this. And I ask my CTO, the chief technology officer, can we do this? And then his face will turn red and said, of course we can do it, but it will take time and money. And I'll say, but we don't have time. And then I'll say, well, then give me more money. You know, things like that. If I had just learned a little bit earlier on, would have saved a lot of money. Another thing is to do customer discovery. We've changed our product left and right, blah, blah, blah. I think it's finally to an okay point, but if we had just done customer discovery, Patricia's probably laughing inside. Like, of course, you start with the customer and the who's going to buy your product, but I didn't. I came up with a thing that I thought would work, and that is not how you start. So fast forward, I still use system thinking. Now I'm flexing it to lessons that I've learned because I have to now teach these classes. Like, oh, my systems thinking was more logical framework. This is more system thinking. You have to assign like responsibility to certain things, but it's kind of the same idea. The point is that it all comes back to you, just like that interception case. The lessons that you learn and apply in one area or at one time will come back. So we're not huge, but I can't tell you how fulfilling it is to go to all these different places and you see nurses, registrars, doctors, pharmacists, pediatricians using the system that you designed. You don't always use it the way you wanted to design, but it's certainly certainly a start. This is an emergency room in northern Sumatra, very remote. And this is, I put this here because this was actually one of our first pilots when we first started in 2017. And the partners took great risks in trying to start something new, but you could see that there was great joy in partnering for change, partnering for good, partnering for a result that everyone could agree on would be good, and that would be that the welfare of ordinary people would continually and systematically and uplifted at scale. All right, that's me. I'll stop and see if there's any questions. And I want to thank everyone for your patience. Sometimes when I finish presentations, I feel like I've gone through like my personal therapy session. But it's very fun to talk about these things.
Wilson, I think there was a question specific to one of the projects or work you were doing on the ground in the chat, specifically to infant feeding from I'm sorry if I mispronounced her name, Olarunda Milola.
Okay, let me see. I can just read it myself. Let me see. Do such babies have to be hospitalized to be fed? How did that go? Also, if there's any situation where babies were sent. Okay, so what I'm referring to is like everyone looks at neonatal mortality. That's death in the first 30 days. 28 days of life. And it's a big deal, right? Like it's really dangerous to be 28 and less days old. That example, I was saying that the interventions that are pushed by the system are not as effective as they can be because the babies are starving during that process. So even though you can save a baby in the moment, which is great, I'm not against neonatal resuscitation, it's kind of fun, but once they are revived, they'll be kind of shocked and stunned, and they won't be fed by the system. Instead, they'll be like, oh, let's do kangaroo mother care and do breastfeeding. And for a significant number of those kids that represent neonatal mortality, they will be sick enough that they will have to be fed through a tube or with formula or both. And so that's what I was saying. But yeah, certainly most kids do not need formula or a tube. 100% breastfeeding friendly. I'm just saying when you're a sick baby, though, you often don't get food. Hopefully that made sense. All right, so let me see. Okay, here I have a question. What were the similarities in Rwanda, Indonesia, and Liberia? They're all the same. That's kind of the crazy thing. And by the way, I'll throw Harlem, where I live. It's kind of all the same. When I say it's all the same, it's like you're going there to be a contributing member of the community. You are joining the community. You're bringing unique skills, but also learning the process. And yeah, you need to have fun. It's all the same. It's all the same. In fact, I would say one of the most fulfilling things about being in global health is that I can land in Kigali, in Dakar, in Jakarta, Bangkok, Guate. I don't really care. I feel kind of at home. And it could be I have mental illness, but probably because it's kind of earned, right? You kind of like have spent enough time there, you're comfortable. And again, going back to, and if you're not immediately comfortable, I'm not saying don't do it. It takes time. It takes a little bit of time, but if you give yourself a little bit of grace and time, patience, and other people grace, time, patience, you'll find that it's all cool. Like we're all human. I know that sounds crazy. I don't want to say the word kumbaya, that drives me crazy, but I will say that it's all the same. To me. Okay. Let me see. I'm interested in developing, okay. Let me see. I'm interested in developing global interventions, but I'm not sure I want to spend months in a year in a different country. Do you know? Oh, that's a good question. Like, this person has the French fry thing I had, right? You're kind of like, you want to do it, but you don't really want to stay so long. And I would be candid and say, you gotta, you're not even gonna know what you're doing for 6 months, if not a year, right? And even if you were effective, let's say from New York, because in the Ebola response, right, I was mostly working out in New York, and then I'd come into Liberia, but people don't listen to you. They're like, screw you, you're sitting in and drinking like a cappuccino in your office in New York, and I'm in the field. I'm not going to listen to you. So at least initially, until you become like the director and people have to listen to you, I think you kind of have to do it, but it won't be a sacrifice. Like I lived in Liberia for 4 years. There are 4 restaurants in all of Liberia. I was happy as a little clam, right? It doesn't, all you need to be happy is community, feel like you're different, like in some way, and feel like you're making a difference. You'll be happy. So I would say at least initially while you're young, unless the person, talked to me is 85, I would work in the field. You'll love it. You'll love it. What is one quality a public health provider should possess irrespective of their field? I mean, I think it's different for everyone, but I think in public health, you better like your constituency. I mean, you better like, whatever, you don't have to be a doctor. I hope you didn't think you had to be a doctor after this presentation. What I'm trying to say is that we are trained to look at very big picture fixes. But if the big picture fixes are not personalized by living in those places, being with those places, having friends of the people, quote, you're serving. Isn't it weird? Like, oh, I'm going to do all these interventions, but at 5 o'clock, I'm going to, like, take my Jeep and driver and go to and have cocktails in the, in the hotel that no one can, afford except the foreigners. That becomes a problem. And there are iterations of that even here in the United States about a separation. So I would say maybe the one quality would be, joy in community, and therefore working hard for community in the ways that need to be done. Okay, should I answer one more or should we end it?
I think we have time for one more. If you
Okay.
want to take a stab, yeah.
Okay, Patricia, you want to pick one? I can't. I just got reading
Um,
glasses, but I'm not comfortable enough with them.
yeah. So we have one from Stacy. How do you feel like your perspectives on public health has changed as you worked around the world, and what advice do you give to an incoming student in the field?
My perspectives, and my wife gets mad at me for this, doesn't really change. I mean, I'm kind of the same person. However, I do think for challenge and for bad, the rules have changed a little bit. Like right now, it is kind of hard to do what I did. It's harder, like because of the awareness, the correct awareness of the colonial construct of aid, bilateral construct of aid. Organizations, including the IRC, they kind of don't like to send us Americans to the field. Now, I think that is kind of like throwing the baby out with the bathwater, because I think, I remember my first interview with Partners in Health medical director, Joya Mukherjee, and I said to her, I was very young and very ideal, and still ideal, just not young. I said to her, I know I'm going to Rwanda and I know I'm going to learn a lot. Like I know don't know traditional medical practices, and I'm totally open to it. And she said, what are you talking about? You're going there to help create a hospital, right? They don't have cadavers for dissection. There are no x-rays. You need to deliver Western medicine at a system level skill with kindness, but you're still bringing it in. So I think what needs to happen is that we still bring in the skill, but I think of the greatest triumph for me in Liberia was not to create that poster, but was to elevate a nurse assistant to the level of clinical director. That person now runs the diabetes clinic that I started. That person continues to improve Liberia, whereas I haven't really said Liberia for a while because I'm not there. And so I think the challenge is to go abroad, but there are ways for organizations to still do that without being so bilateral. So I was like, whenever I go to a place, I always train someone to take my place. Like, it is true. Like, the best leadership is you die and people are fine, right? I mean, sad, but you died, that's fine. So in terms of the intervention, hopefully people like shed it here. But yeah, so that was my approach to it. That thing has changed, but like I think the awareness, the awareness is better, but I think there has been a little bit of a, cutting of the whole arm off for the wart. But come here and I'll help you get out. I'll help you get to the field.